Please. I'm going to speak from a unique perspective because I am a chaplain. My name is Reverend Charles.
Might not be working.
Hello. My name is Reverend Charles Monaco. I'm an interfaith minister. I'm an associate chaplain. I'm a movement therapist, a music therapist, and I'm trained in bereavement and end-of-life care. I've worked about 7 different institutions, both home-based and in this city. What I'd like to address is several things. Number one, most communication is nonverbal. If that be the case, then the creative arts have to play a role in the team's work, because through the creative arts, the moment of life review reveals itself, and the sense of selfhood normalizes. This relationship to the staff and the family that are their caretakers organizes itself and presents the basic meaning of one's identity in life at these healthcare transitions. Where do you see the creative art therapists, the music therapists, the movement therapists, the poetry therapists at this table, and how we're going to institutionalize what we already know if we look at the statistics, not just quantifiably, but qualitatively, will make a huge difference. I got to practice this, but you know how? I put it all together on the low end of the professional spectrum as a recreation therapist. I get to normalize the relationship of the creative arts and the person's identity in the daily experience and bring to life through the joy, both by my modeling, the passion I have with all of these experiences, and finding out what's unique to the individual and bringing it to life for them and their immediate community. With the floor nurse opening their mouth and saying, that person never spoke. With the CNA saying, oh my God, they're moving a maraca, how could that be? With the male aide with men, with a men's group that I work with, saying, wow, they're really talking about their feelings. I mean, this is done through organizing all of these disciplines into one act of normalization, which I get to do as a recreational therapist. So my question is, where do you bring the activity of recreation therapy, the life review process, and the creative arts together so it can inform the entire plethora of professionals and end-of-life care? I know because I got people to speak about their end-of-life preferences when they can't talk. I did what the social worker who worked with them for 2 years couldn't do. I know what I'm talking about, and I hope it can be addressed systematically in your new models. How do you plan to do that?
Well, I guess the question is, how do you plan to do it as a recreational therapist? I would say, as a if you were a chaplain, on your chaplain hat, I would say, how do you convey what you learn to the team so that it's incorporated into their care? We chaplains have been hiding our, do this a lot. We go and we learn a lot, and then we don't tell the team.
But I'm part of an interdisciplinary team that discusses these matters.
Good, so there you go.
They wait for me to inform them what the next
There you go.
practice
So,
will be. I'm a health educator and I'm trained medically, so I can talk anyone's language. The question is, what is the nonverbal language that unites everyone in witnessing and creativity and God-given divinity, which we all carry as an essence of who and what we are? That's the question I think we need to be answering at today's conference.
If I could answer that question, I would have written a book and several books and retired. But
I do think part of the answer is that as we focus on person-centered care, their sense of art, their sense of creativity should be part of that, and we will acknowledge that it's going to take a team with multiple perspectives and multiple disciplines, and it's a learning process, and you could help shape that learning. Yes?
I think you should give him a blank paper.
You better give me what I can, because we're going back to my job in another 10 minutes, so if you want my input, will someone give me your card so I know where to find you?
One comment and a question, and I think answer to your question is what CTEC can do. The comment is, I don't know if you can hear me.
Yeah, we hear you.
Yeah, there is a difference between culture and religion, and we need to remember this, because when we care for our patients, remember a case of a Chinese man who became dehydrated because he was not drinking water because we were giving him ice water, and ice water in their culture is unhealthy. So culture, we need to know that when we are dealing with people at any time in their life, particularly in the healthcare setting, other than their religious values or spiritual values. Answer to your question, what CTEC can do, I read medical journals, I read the newspapers. I have never heard of CTAC. I'm glad that this town hall type of meeting is taking place. So we, the community, needs to learn more about the group's work and what successes you have had in terms of policy being in Washington, D.C. This model that you're referring to, it will be something, because we are moving into the ACA, the Affordable Care Act, the Obamacare, in which we will be caring for the communities, and we will be doing an integrated model of care. So I think to promote that, to propagate that, we need to learn more about groups like this so that we can bring it to the table at my dinner table at home, or in my community, or wherever I sit and meet. So I think we need to move fast on this so that we can bring back, and these models are for the whole health care, not just the end-of-life care. Of course, that is part of this component in that general medical care.
Yeah, I think there is some literature published. There's Gary Gunderson has done some work in Memphis along the same line. Now in Wake Forest, Malcolm Marler in Birmingham. That work is all published. I forget where Gary's work is published, but I could find it for you if you give me a card. I think Christina Bahalski and the Global Leadership Network that's in spirituality and health that's funded by Fetzer, that was published in Journal of Palliative Medicine. It's not the Lancet, I get it, okay? And not that, but we're getting there. And so there's some starting, but you're right. It's not out there very much.
Let me also respond to your concern. I'm excited that you're really raising this, because one of the things from my faith tradition is you don't put your light under a bushel. And
Let it shine.
there are a lot of lights under bushels across this nation concerning this particular issue. But let me go back to what I said earlier. CTAC is a movement, and the movement includes you and me, from different cultures, from different traditions, and also from different racial, ethnic, and backgrounds that are in folks in poverty, or folks who are, quote unquote, I'm using that quote, disadvantaged. It is a movement, it is a people's movement that we are encouraging all of you to engage in. And we will make sure that you get the information. We will make sure that you have the web page and all of the information. But we also are encouraging you, when you go into your sessions, your breakout groups, to think about what your needs are and what you see as ways of transforming your particular communities in ways that not only CTAC, but also the Interfaith Center could be helpful in having you engage in a broader dialogue, but also in this greater movement. I'm just really excited again for the Interfaith Center and their participation in this, because as I said earlier, this CTAC started in a moment of crisis. And now we have developed our mission, and we are engaged now in a movement. And to me, this is your moment. You are developing, or hopefully will develop, your mission, and hopefully after this session, you will be engaged in a movement. And so I just encourage you to engage yourself and test and to see where this goes.
The movement can be small also. It could be going home tonight and talking to your loved one at home about your wishes and understanding what their wishes are. So it can start at a very personal level. By the time people come to the hospital at their end of life, often they're already non-participants in their care. So it really, your ideas from my mental health background, the creative arts were a way to break through the schizophrenic's thought process and speaking, to find out really what was on their mind rather than the words that no one could understand.
These
But
might appear
we took care of those patients for long
But
periods
they may
of
feel like,
time.
it may feel like a miracle.
And-
But if you're in the moment of engagement, you realize what's going on. It's a simple
Correct.
revelation of the person's soul to us
But
and the healthcare team.
But
It can be
taking
seen.
these functions and talents to the larger communities and populations, rather than staying focused in the hospital, I think where the most success would be.
So I'm going to give all of you some homework to do. The first is, you've heard it more than once, everybody here should have an advance directive. Everybody in your family should have an advance directive. Everybody in your community has to have an advance directive. Second, something nobody said, if you do have a house of worship and somebody used to be sitting in a seat and they're not in that seat, find out where they are. They could be sick at home. They may really need your care. And the third is, you know, my grandmother used to say in Yiddish, there's an expression, you have to be lucky in life and you also have to be lucky in death. Join the movement that Tyrone is talking about. Take some of the luck out of it for people. It shouldn't be luck. Everybody deserves good quality care. We're going to break into groups now, and Sarah's going to give you instructions about where to join your groups. Bring those blank pieces of paper with you.